Will now come to order. The chair now recognizes himself for 5 minutes for an opening statement. Welcome to today's hearing. Today's hearing is a chance for members to check up on the implementation of Medicare Access and CHIP Reauthorization Act of 2015, more commonly known as MACRA. I believe we're in a better place now than we were prior to 2015 because of the work done by the members of the Energy and Commerce Committee, led by Dr. Rodgers, to get MACRA enacted into law with overwhelming bipartisan support. MACRA charted a new course for Medicare and attempted to put it on a more sustainable financial path. MACRA was designed to shift physician reimbursements from a fee-for-service payment model to one that seeks to reward doctors for value over volume for patient care. One of the biggest pieces was the elimination of the sustainable growth rate, or SGR. This was the formula used to determine the annual updates to the Medicare fee schedule, which governs physician reimbursement. On top of eliminating the SGR, MACRA established the Quality Pay Program, which establishes two pathways to incentivize physicians to transition to value-based care. One pathway is the Merit-Based Incentive Payment System, or MIPS, where a provider is subject to a performance-based payment system that results in payment adjustments based on certain quality reporting categories. The other pathway is the Alternative Payment Model, or APMs, which allows physicians to take a risk-based approach to treating patients to achieve specific performance goals in order to receive bonus payments. This hearing will allow Congress to understand what's working, what's not working, what's showing promise, and what unexpected challenges have come to light. Among these unexpected challenges is CMS's implementation of MACRA that has created additional levels of administrative complexity and costs. This has slowed down the adoption of MACRA's quality payment programs. Savings achieved under these models have also been less than was hoped for, and CMS's process for approving new payment models has been something of a disappointment as well. In 2020, less than 238,000 providers were participating in APMs, while over 933,000 participated in MIPS. MIPS has also proven administratively complex to implement and costly for providers. This has disadvantaged small and rural healthcare providers and in many instances prevented them from participating in the program on a level playing field. It is essential that these rural and underserved providers are not left at a disadvantage due to the lack of resources and infrastructure. A small rural practice needs standards that are relevant to their practice and different than the larger suburban practices. These issues risk further accelerating the consolidation of healthcare providers. We've seen too often doctors are forced to pay attention to certain metrics to ensure reimbursement rather than for quality patient care. We must strike the right balance between fairly compensating our doctors and healthcare providers to ensure access to high-quality care while also being good stewards of Medicare funds. I will now yield the remainder of my time to a leader on this issue, Dr. Rodgers.
Well, I thank the chairman, and as he pointed out, the SGR's unrealistic expectations of spending and efficiency affected the healthcare profession and Medicare beneficiaries for nearly 17 years before the final repeal. At the time, docs were facing a 24% cut in Medicare rates unless Congress stepped in to provide a more straightforward reimbursement system for America's physicians. The Medicare Access and CHIP Reauthorization Act introduced the new merit-based incentive payment system and processes to adopt alternative payment models. This new system shifted the approach to physician payment, paying providers based on quality, value, and the results of care delivered rather than just the number of patients seen in a day. I've dedicated a large part of my congressional career to repealing and replacing the sustainable growth rate formula, and obviously the follow-on, the enactment of the Medicare Access and CHIP Reauthorization Act. This was a major milestone in 2015 and was supported by over 800 healthcare organizations, overwhelming support in both the House and the Senate when it passed. This legislation was the result of bipartisan multi-committee negotiations that produced legislative responses to some of our nation's most pressing healthcare issues. It is important to note that we were solving the problems of the time and that our shared goal was to help doctors and their patients be relieved from the constant threat of payment cuts and doctors dropping out of the system. The repeal of the SGR took me personally 13 years from start to finish, With a product as comprehensive and complex as MACRA, it was short-sighted of Congress to assume that the need for oversight would stop after the signing ceremony. I thank the chairman for this opportunity to examine what worked and what didn't work, the agency's role in implementation, and how we can make it easier for doctors to practice in our healthcare system. Our work is far from done, and docs deserve a long-term financial stability, and patients deserve access to the best care possible. Thank you, Mr. Chairman. I'll yield back to you.
Gentleman yields back, and I yield back as well, and now recognize the ranking member of the subcommittee, Ms. Castor, for a 5-minute opening statement.